Thank you so much, Professor Mohammed Sabhi. I'm Dr. Juwairiya. I'm the president of Emirates Cardiac Society, and I would like to welcome you all on behalf of Emirates Cardiac Society in this very important educational activity that was briefed by Professor Mohammed Sabhi. So the first wave is today, and for the first wave, we're talking about angina management. As it's a leading cause of death and disability worldwide. It's very important to understand how to manage it early, especially in high-risk patients. And it's also very important to understand the multifactorial aspects that is specifically present in the Middle East. So that's why it's very important to hear from our own faculty. So our first speaker is Professor Sherif Wagdy. He's a CV Rep board member and professor of cardiology in Alexandria University, Egypt. And he's going to talk about the unmet needs in coronary CCS management. So Professor Sherif, the floor is yours.
Thank you so much. It's a great honor to share with you with Emirates Society of Cardiology in this elegant course of Heart Masters. Actually, I'll be talking about the unmet needs in chronic coronary syndrome management. We all know that we have multifactorial pathways for angina, and still we are having cases that are not responding and facing anginal attacks despite the full medical treatment. Why we are still talking about ischemic heart disease? Ischemic heart disease is now still the #1 contributor to mortality among the cardiovascular disease, and even bigger contributor than the most common cancers. You can see from the diagram that ischemic heart disease accounts for 18% in females and 17% in males for mortality. While if you look for the combined cancer, colon, stomach cancer, colorectal colon, lung cancer, breast cancers, all of them, they are not as much as bigger contributor as ischemic heart disease. That's why we need more and more evidence and more improvement in the management of this disease. In North Africa and in Middle East countries, stable angina is the biggest contributor to cardiovascular disability. So it's not only the cause of mortality, but it also increases cardiovascular disability. Your patient is not able to perform his daily activity, he is not able to perform his jobs. That impacts the socioeconomics of the global country, and that's why we still have to face a big burden to improve the outcome and to reduce this cardiovascular disability that has many impacts regarding the socioeconomics of the country. Angina, where are we now? So we are having angina pectoris, we have economical, as we said, and we have personal factors that are affected with angina. So disability is increasing threefold, job loss is increased 1.5, and depression is increased about 4% in patients suffering from angina. It's very harmful that you cannot practice your daily activity, go to your job. Every time you do any effort extra, you are having anginal pain that lead you stop and you cannot discontinue your practice or your job. That's why it is a very important topic to be addressed, and we need to tackle this impact. Generally, economically, angina frequency is directly related to the risk of rehospitalization for acute coronary syndrome and associated cause. So it is not only a symptoms that can lead to disability or it can lead to depression, but also it is related to the rates of rehospitalization and acute coronary syndrome. So when we look for the sub-analysis from the Berlin TIMI 33, we can see that the patients that are having frequent anginal attacks are at more risk of rehospitalization for acute coronary syndrome and subsequently higher mortality. So angina is not only a symptoms, but it is also related to the prognosis of the patient with chronic coronary syndrome. The higher the anginal attacks he is suffering, the more the rehospitalization rate and the more the incidence of acute coronary syndrome. Ischemia and anginal symptoms define prognosis irrespective of the coronary stenotic burden. It's not related only to the degree of stenosis you see in the CT coronary tomography or in the coronary angiography. So angina is also related to the prognosis of the patients. It's not only the degree how much is having stenosis is in coronary artery, but it is directly correlated, as you can see from the diagram, that patients with frequent attacks of angina and are at higher risk of mortality compared to those with lower incidence of anginal attacks, despite the difference in the degree of stenosis found in the coronary angiography. This is either in male or in female, either below 60 years or above 60 years. Patients suffering with daily or weekly angina are at having very frequent we are facing. So when we look for this diagram, that we can see that the number of anti-anginal medication, even despite the new hemodynamics medications we are having, even those who are still on 4 number of anti-anginal medications, they are still having anginal symptoms. That's why we need more and more treatment to improve angina and to reduce the frequency of the ischemic attacks or the anginal attacks. What do the recent guidelines say? I know Dr. Abdallah will elegantly present the recent CCS guidelines regarding the management of chronic stable coronary syndrome. But we can see from this sub-analysis from the last guidelines 2019 that there are unconvincing data on anti-anginal efficacy of combining the first-line anti-anginal treatment, the beta blocker, and the CCB. So when we look for this sub-analysis of 22 studies regarding the chronic stable coronary syndrome, we can see that the conclusion of these trials said that the beta blocker and the calcium channel blocker in combination don't present significant efficacy versus using either one of them alone. So adding beta blocker to CCB in management of angina didn't differ when using single anti-anginal, and there is no data on long-acting nitrates about the efficacy in improvement of anti-anginal medication. That's meta-analysis of 22 studies, as you can see. Even when we look for the famous ORBITA trial, the ORBITA trial demonstrated that optimization of anti-anginal therapy with 2 or 3 hemodynamic drugs doesn't relieve angina. So even those who are target bisoprolol, amlodipine, and calcium channel blocker, long-acting nitrates, despite the use of 2 or 3 hemodynamic drugs, they still didn't relieve completely angina. That's why we need more medication that act at the cellular level, not only hemodynamic modifying drugs as the beta blockers and the calcium channel blockers. And this is the PCI on top from the ORBITA trial again and the ischemia trial. We can see that the PCI on top of the optimal medical treatment didn't significantly improve the SQ summary score regarding the angina frequency, physical limitation, quality of life. So despite the PCI, despite the hemodynamic drugs, we are still having our patient having frequent anginal attacks. That's what we call the unmet needs, despite the proper anti-hemodynamic medication and despite the proper PCI and revascularization, there is some missing or unmet needs, which is mainly due to the cellular level, which needs more improvement to reduce the anti-anginal effects. And this is when we look for all famous trials regarding the revascularization, as the Syntax, as the Courage trial, the ARTS, the FAME trial, all of them, there are patients still having recurrent or frequent anginal attacks despite proper revascularization with PCI. That's why we need more medication to improve these unmet needs of angina, which has direct relation to the prognosis of the patient. Another important review was published in the New England Journal of Medicine regarding the low diagnostic yield of coronary angiography. In everyday practice, we face this, that the patient referred with typical anginal symptoms and referred you to the cath lab. And when we do the coronary angiography, we have normal coronary. So you tell your patient, it's congratulations, you don't have any obstruction, you don't need to take any medication, but your patient is still symptomatic and he is suffering from the anginal attacks and it is impacting his daily life activity. And this is about 60% of patients referred to the cath lab had a coronary stenosis, which is less than 50% or non-significant coronary stenosis, despite having typical anginal symptoms. And 40% of all patients undergoing coronary angiography are found to have normal coronary arteries or non-obstructive coronary artery disease. That's why we need to look for further pathophysiology beyond the obstruction or beyond the stenosis in the coronary artery. So treating angina patient with hemodynamic agents as beta blocker and the CCBs alone is not sufficient. And we have seen that from the data of the Orbiter trial and meta-analysis of multi-trials we presented. PCI on top of the optimal medical treatment didn't significantly improve the SQ summary. This was conclusion of the ischemia trial. Consistently high rate of persistent recurrent angina after successful PCI, and this is from meta-analysis of several trials, including the Courage and the FAME trial. 40% of all stable angina patients undergoing coronary angiography are found to have normal coronary or non-obstructive coronary artery disease. That leads us to the question, does this common understanding for angina work now? Is it always the problem of the blockage of the coronary, or there is something else beyond the angina or the symptoms of the chest pain? So angina is a disease caused not only by coronary obstruction that can be fixed by mechanical or hemodynamic means, but we have several pathophysiological mechanisms that can cause the angina. So we should always look the overlap between the hemodynamic obstruction and the cellular mechanism. So we can have coronary spasm that can lead to the angina. We can have a problem at the level of the coronary microcirculation, either at the arterial level or the capillary level. We can have functional obstruction due to abnormal vasodilatation or endothelial function. We can have myocardial problem as patient with left ventricular hypertrophy, calcium overload or induced obstruction, and we can have also structural mechanism. So treating angina is not only treating the obstruction and the hemodynamic impact, we also should look for the cellular level to improve the angina of your patient and subsequently improve the prognosis and the outcome of the patient. So the take-home messages, ischemic heart disease is still the #1 contributor, as we said, of mortality among the cardiovascular disease, and even bigger contributor than the most common cancers. We have a problem in North Africa and Middle East countries. Stable angina is still the biggest contributor to the cardiovascular disability, despite the existing treatment strategy and the improvement of PCI techniques. Angina has a great economical and personal burden, as we said, as it can lead to depression, disability, and job loss, and its frequency is directly related to the risk of rehospitalization and acute coronary syndrome, and subsequently associated cost for treating this acute coronary syndrome. Based on the below findings, treating angina patient with hemodynamic agents as beta blocker and CCB is not sufficient alone. It should be combined with medications that act on the cellular mechanism. PCI on top of optimal medical treatment didn't significantly improve the SQ summary score regarding the angina frequency, physical limitation, consistency, high rate of persistent or recurrent angina after successful PCI, and we don't forget that 40% of our stable patients with angina are found to have normal coronary angiography during the coronary angiography, and we should change our concept in understanding and managing chronic stable syndromes, not only treating the hemodynamic effect, but we should also tackle the cellular level to improve the outcome of patients with CCS. And thank you so much.
Thank you, Sherif. This an excellent talk. If you allow me, I have a lot of information. I jumped sum up of these informations that you said, that there is increased mortality with ischemic heart disease. There is what's known two definitions. I would say stable, and old one is chronic stable, and then chronic coronary syndromes. There is physical limitation, economic burden, frequently angina. Then we come to that it's not only hemodynamics, maybe it's metabolic, and then different trials. My question to you, first questions, and you can join with the other questions, that how can you know that this patient will not benefit from hemodynamic drugs? I mean, beta blocker, calcium channel blocker. You have a patient We have, vessels, you have microvessels, you have myocardium. But if any patient come to you on clinical basis on non-invasive technique, how do you know that this patient will not benefit from hemodynamic drugs like beta blocker, calcium, and you should add a second anti-angina or
Usually,
metabolic background?
yes, usually as a first line of treatment, as the guidelines are still recommending that we should start first with the hemodynamic medication. If your patient improve, and this is usually we don't see a lot with the hemodynamics medication alone, that's okay. You continue on this hemodynamic medication besides the antiplatelet medication and the statin therapy. But if your patient is still symptomatic, even if you have any form of non-invasive, like the CT coronary angiography, and it says that there is no obstructive coronary lesion, we should respect the symptom of the patient. So if your patient are still complaining of chest pain and the frequent anginal attacks, we should start immediately the medications acting on the cellular level to improve the symptoms of the
This comes
patient.
to the second question regarding INOCA. I mean, INOCA, that you mean coronary disease without obstruction,
Non-obstructive, yes.
non-obstructive, but you should do some form of coronary physiological parameters. I mean, you should do something like IFFR
IFFR,
or
yes,
IMR. I mean,
yes.
index of myocardial resistance. Are you allowed to do this? Or maybe in the future, maybe in the CT, but how can you make it in these patients? You do an angiogram for all these patients, do normal coronary, but you prove that this patient had the positive stress epithelium, and then you give, or you should do coronary physiological invasive management
If you have
parameters. Sorry.
if you have in your core lab invasive assessment and the patient is already during having a coronary angiography, so performing an IFFR is ideal to diagnose this type of patient with MINOCA or non-obstructive coronary artery disease. But sometimes it's not available, or even in some
Yeah.
cath lab, it is not reimbursed. So we can manage this by combining. So we can do a Salium combined with the coronary angiography to see or the significance of this microvascular or problem, and start immediately the medication necessary.
Okay. Dr. Jira, do you have any question to Dr. Sherif?
I think Dr. Sherif, mashallah, he did an excellent job covering this issue. And I think you covered mainly most of the important questions. Should we prove that this is angina, or should we just treat the patient? And sometimes we're limited with resources. But I think, Dr. Sherif, if you can you explained like the mechanism of angina, there can be multiple mechanisms, either obstructive or non-obstructive. So how important is targeting cardiac cell therapy for therapy of angina and patients? How do you think how important that is compared to hemodynamics?
Yes, I think it's very important because it's improving the microvascular circulation and improving the metabolism of the cardiac cells itself. It's very beneficial regarding the optimum use. Even if you are having some obstruction, it can benefit. You are increasing the benefit of performance of this myocardial cell, and subsequently improving the outcome regarding the future acute coronary syndrome.
Sharif, you mentioned different trials which make some revolutions regarding the management ischemia, which is starting with carriage. You know that there is a 10% sub-study that this could be PCI patients, and Orbita is about question about the Orbita, the mechanism, how the design, and then the ischemia, which is I think one of the most important trial, and finally the FAME. Actually, we just have a FAME 3 now. How can you illustrate this in your practice? Orbita, carriage, ischemia, FAMEs.
I think they all came to the same conclusion, that treating patient with chronic stable angina or CCS patients, if patient is responding very good with the anti-anginal medication, with the medical treatment, and on non-invasive imaging, we don't have evidence of large burden of ischemia, keeping those patients on the medical treatment is as equal as performing PCI. That's the main conclusion. So we don't do PCI for patients with chronic stable syndrome or CCS patient. controlled on the medical treatment, and you have evidence on non-invasive imaging that you don't have a major or large amount of myocardium at risk of escape. I think that's
Karim,
the
you have
major.
any question? Karim. Okay, if
Thank
you
you,
enjoy.
thank you, Professor Sherif. It's an elegant presentation. I just to focus on what you have said regarding respecting the patient symptoms. It is not always about improving the prognosis and mortality. Patient symptoms is very important and very crucial. Our rule is to improve the quality of life, not only to improve the survival. The patient with improved symptoms and improved exercise capacity can be an active member. So we should do our best to control the patient symptoms. The next point regarding the prognosis and regarding the revascularization in chronic coronary syndrome, as Professor Sobhi asked, I believe that the patient with left main and proximal LAD, those patients are prognostically are very important to revascularize. Otherwise, the medical treatment can do the job in the patient with chronic coronary syndrome as far the symptoms are controlled with medical treatment.
Dr. Jilri, any questions?